Great. Well, it's wonderful to learn with everyone in these challenging times, and this is the first of a series of four here in talking about different halachic issues that have come up in the wake of coronavirus, different areas. This one is the most medical of them, and in some ways the most difficult to grapple with because just the content, the material itself is just very troubling. And so we're going to talk about something that hospitals have been facing over the past couple of weeks, the question of triaging medical care. Usually we live in a world where, thank God, we have such, so many resources devoted to healthcare and such advanced medicine that usually, certainly in America, the potential is there to give people all the healthcare, all the care that's available. And what's so challenging is in the last few weeks with just the onslaught of the coronavirus, there's been so many people in hospitals, especially in the New York area and in some other areas, in Italy and elsewhere, that the healthcare system has to a large degree been overwhelmed. And the challenge is how best to use the resources that the hospitals have to help as many people, to help save as many people as possible. So this is not just a question in medicine, and not just a question in ethics generally, but it's a question in halacha as well. What's halacha's perspective in terms of how to apportion resources? So we're gonna jump in. We're gonna jump in now to the source sheet, which I should have just shared the screen with all of you. You should be able to see it, and just starting just with a few headlines of some of the issues that have been facing. As recently as 2 days ago, the New York Times ran an article about all the innovations used in place of ventilators. Turning people on their stomachs, using other machines in place of ventilators, because there certainly aren't enough ventilators. Very often, people with advanced cases of coronavirus, you put them on a ventilator to help breathe for them until they clear the disease. And so not only have there been shortages of ventilators, but the question of who to give the ventilator to, there's also been the question of splitting ventilators among multiple patients. There's been a little controversy over how well that works or not. And now, at least in New York, it seems like largely we've turned the corner, and there are people who are already running articles, the ventilator shortage that wasn't. That certainly hospitals were tight, and there were cases of people not getting the treatment they would get under normal circumstances, and there were cases of trying to share, and as we saw, of cases of using alternative therapies, but it wasn't as bad as was worst feared. There was a real worry that people just wouldn't get the treatment that they needed, and luckily it didn't reach, or at least at this point hasn't reached that, and partially because flattening the curve and things getting better. But we're going to consider the questions that hospitals have been facing, and I think at least in some parts, some places still continue to face, as to how one would apportion one's medical resources, not just ventilators, but other resources as well in these challenging times where hospitals don't have all the resources that are necessary. And we're going to start by surveying some of the more classical treatments of this issue, let's say in the 20th century and until recently, but then we're going to jump into the particular issues that have come up in just the last month or two by coronavirus, and we'll consider the different halachic issues and the different values that come into play among the poskim. Just hopefully everyone should be seeing the shared screen now. Is that correct?
It looks like it. Yep.
Yeah. Okay. So we'll just look up. I will pull up some of the headlines that we went through before. And now we'll move to some of the basic principles of medical ethics. This graphic I found online has, just as a picture, a pictorial representation of the four principles of medical ethics in general, not particularly in Judaism. The four principles are justice and autonomy. We'll talk about those in a second. The two most basic ones are beneficence, to do good, to save lives, to help people avoid pain and achieve health, and non-maleficence, do no harm, as it's often known. Those are maybe the two most, the most straightforward principles. And the question is, what we're going to face is what happens when they run up against one another in some ways, where you don't have enough resources to help everyone, so you're going to help one person, but it will come at the expense of someone else. You have to balance beneficence with non-maleficence. And in cases like that, that's where justice comes into play. Justice in the sense of distributive justice. How do you decide how to give out the various resources that you have, in this case, medical resources? The principle of autonomy, which often is a big differential factor between Judaism and Western medical ethics, where Western medical ethics certainly recently has a major emphasis on autonomy. Judaism, it's harder to find sources focusing on autonomy, on patients being able to say, I want this treatment and not that treatment. In this case, we're less focused on individual patients, just because it's such a massive issue, that the questions here are, how does a hospital balance between the patients? So the autonomy of the individual patient is less of an issue here, which also means that that gap that often exists between halacha and Western medical ethics systems comes up less so. With that in mind, let's just take a quick peek at some of the sources in Judaism that parallel these principles. The pasuk says, source number one here, Lo samod al dam re'echa, don't stand idly by the blood of your fellow. That would seem to be an obligation of beneficence. One has the obligation to help others, certainly where their life is at risk. One must do so. And then the next source, the Gemara in Sanhedrin, talks about, also cites this pasuk, Lo samod al dam re'echa, and it brings it up. It brings it up in the context of minayin l'roach es chaver shu tovea b'nahar. If you see your friend, your fellow, drowning in the river or attacked by animals or bandits, shu chayiv latzilo, you have to save them based on this pasuk. The previous page in the Gemara in Sanhedrin actually qualifies this a bit, and it talks about a case, a couple different cases, but one is a case where a mother is giving birth to a baby, or a new mother, and there's for whatever reason there's a health difficulty, and the baby, if the baby's born, the mother will bleed to death, and the choice is you can only save either the mother or the baby, and the halacha is prior to the baby being born, the pregnancy can be terminated, or really should be terminated, to save the mother's life. But in a case once the baby's head comes out, yatsa rosho ein nogimbo, you can't harm the baby or can't kill the baby to save the mother. Lefisha ein dochin nefesh mipnei nefesh. We have a principle here, and this comes from non-maleficence. You can't do harm. You can't set aside or push away or really kill one life in order to save another life. That's the principle of ein dochin nefesh mipnei nefesh. And then there's a whole discussion about rodef. We're not going to get into the details there, but this is a very important principle that we're going to see over the course of this year, that it's imperative to save lives, but you can't save one person's life at the expense of someone else's life. Ein dochin nefesh mipnei nefesh. And part of the logic of that is explicated in the following source. There are, Judaism generally is a very big supporter of human life, and we saw this in shutting down all the shuls and all the religious institutions just a month ago, for the reasons of pikuach nefesh, to save lives. There only are 3 categories of commandments that override that, the 3 are avodah zarah, gilui arayos, and shvichus damim, idolatry, sexually prohibited activities, and for our purposes, murder. So you can't kill someone to save someone's life. And that source number 4, the Gemara says, that's a svarahu. That's logic. You don't even need a proof text for that. And it gives the scenario of someone, Mari Durai, Amar Zil Katle Leplanya, V'ilo Ketilnalach, Amar Liktalach Lo Tiptol, My Chazis Damadidach Sumaktve, Dilma Damadau Gavra Sumaktve. If someone puts a gun to your head and says, kill someone else, you should be killed rather than killed, because who's to say that your blood is redder than the other person's? Who says you're allowed to prefer your life over that of the other individual? So that's a very important principle here. So there's an obligation to save, beneficence. There's a prohibition against harming, against killing others, even if it saves a life, non-maleficence. And the question, of course, is how these come together. When you have a scenario where there's limited medical resources and you can save one person, but it'll have to come at the expense of someone else, how does one balance between these scenarios? And for that, we'll jump in now to the basic principles of triage in halacha. Maybe the clearest and, as far as I can tell, very often cited or paraphrased summary of this is by Rabbi Avram Steinberg. He's the consultant, I believe, for Shari Tzedek in Israel for their hospital. He's a medical doctor, also a very knowledgeable Talmud Chacham. He's one of the editors in his spare time when he's not working in the hospital, one of the editors of Encyclopedia Talmudit. So he has many, many writings on halacha and medicine. Here is his summary of the basic principles of triage, which we'll sort of run through. So in a case where you have mispar bnei adam haskukim letzipul matzil chayim, you have many people who need life-saving medical attention. They all arrive at the hospital at the same time, and you can only treat one of them. And this is a case where, of course, the means of saving belong to a third party, like a hospital. So he says, if the idea, im yesh sham echad shesikuyav harefuyim leafik to'elat me'atipul latzlat tovim yoter me'acherim, if there's one person who is sort of a better candidate, who's more likely to be saved than the other ones, hu kodem le'elu shesikuyim harefuyim shelahem klushim, the person who has the highest likelihood of being saved takes precedence. We don't follow the order in the Mishnah and Horios, which we'll see later. Therefore, he says, lefikach bari u'mesukan bari kodem. In a scenario where you have two people, one is healthier than the other, meaning one's chances of recovery are higher, then you save the person who has the higher chance of recovery, assuming v'hainu she'abarihu mi shetzarich tipul refu'i, the person needs treatment. And actually spells this out elsewhere. There's really, if you have sort of three different levels, you have people who, let's say the examples, sadly, the examples often given here are terrorist attacks. After a terrorist attack, you have three different types of people, who are injured. People who, they sort of have a cut on their arm or whatever. They're not really in danger. Their life is not in danger immediately. You can treat them in an hour and they'll have the same outcome. Those people, obviously, those are not a priority. You have people whose situation is very, very dire, or even if you treat them, you're going to try to help them artificially breathe or restart their heart. The chances of them recovering are very low. And then you have people in the middle where, let's say, they're bleeding out, they're bleeding heavily, and if you stop the bleeding, if you help them, there's a good chance of survival, and they need it. So that middle group is the group to focus on. That's how it's often formulated. So those who need medical attention, their life is really at risk, but they have a high chance of a positive outcome. Those are the people to treat first. And related to this, he writes, if you have two people, one of them, even if you save their life, they won't be able, they only have a few months left to live. Let's say a terminal cancer patient, where they have some immediate health challenge, but the larger health challenge is that they are not going to live more than a few months. In that case, you save the person who has a chance to live longer term, and that's often called what he refers to as chaye olam v'chaye sha'a. You can prolong someone's life by a short period of time, or you can restore the entirety of someone's life, for however many years that would be. So in that case, you prefer, all things being equal, you prefer a case of a chaye olam, where you can bring someone back to health so they can live their full life, rather than prolong their life by a few hours or days or even a few months. And then finally, and this is maybe the most relevant to our case, if you have a choice between saving many and saving a few people, the kulam shavim mibchina refuit, if they're all equal medical status, obviously you prefer saving the many over saving the few. But here's where it gets complicated. Let's say you have someone who has a low chance of recovery and the doctor already started treating them, and then someone in that middle class who has much better chances of recovery shows up at the hospital, and the doctor can only treat one of them. And he gives parallel scenarios. You can't stop treating that first patient, even though they have a lower chance of recovery than the other one. You can't stop treating them. Even if they have higher chances. Even if this person you save, you're only going to save, they're only going to live for a month maximum after you save their life. It doesn't matter. Once you start treating them, you don't stop. And he gives two possible reasons. He says two different possible reasons. One is Mishum she'acholeh b'chayei sha'a kvar zacha bimkomo, it should say. He gained his place. He earned his spot. He sort of bought his spot, as it were, in the emergency room, and he needs to be treated. Once you start treating him, it's his right to be treated and to be treated fully. That's one formulation of this principle. The other formulation that by Rav Moshe Feinstein, the other formulation by Rav Shlomo Zuckier, that line that we saw before, if you're treating the patient with lower chances of recovery, and then you say, oh, we have a better candidate now who has a higher chance of recovery, will leave you behind, that's a case of dochin nefesh mipnei nefesh. That's like killing the born baby to save the mother's life. And therefore, that is prohibited in this case. Now, there is a minority position that argues, which we'll see later, but this is the standard view, certainly in America, also mostly in Israel. This is the standard view of how to do triage in hospitals. So if people arrive simultaneously, you treat those with the best chance of recovery. Those who, when they recover, will be able to live a full life, are not terminal patients, even if they recover, and obviously preferring to save more people over fewer. But once you start treating a particular person, you don't remove treatment. So in the case of coronavirus, what this would look like is if you have two people who arrive at the hospital at the same time, and one of them has 50% recovery rate if you put them on a ventilator, and they need it, and the other one has a 10% recovery rate if you put them on a ventilator, you'd put the 50% recovery rate person on first and not the 10%. But if the 10% recovery rate person comes first and you put them on a ventilator, you then can't take them off even if the quote unquote better candidate comes along, because that's ein dochin nefesh mipnei nefesh. You can't sort of throw away the life of the first person who came in to the second person. So it ends up being a first come, first served system. That's the first priority on its understanding, with the caveat that if people arrive at the same time, then you treat the better patient, sort of the patient with the higher chances of recovery. I included here a lot of sources that argue for these points. We're not going to go through them in detail, but maybe we'll just skim them. This is Rav Asher Weiss, a current posek in Israel, and a leading posek. So he talks about, again, a similar set of preferences. You prefer a person who will have chayim arukim versus chayei sha'ah. A person will live a full life rather than a person who will only live a few months. You prefer someone sheyesh yoter sikui la'atzilo. You prefer the person with higher chances of recovery to one who has lower chances. Then he talks about the Mishnah and Horios and the preferences there. We'll get to that later. And then, this is very interesting. Tzarich iyun is a big question. Im yesh la'akdim na'ar tza'ir l'zakein muflag. Let's say you have two people. They both, they have equal chances of recovery, and if they recover, they'll live their full lives, as far as we can tell. The only difference is one of them is 20, and the other one is 50. So one of them has one of them is expected to live another 60 years after they recover. The other one's expected to live another 30 years after they recover, just because they're older. So what does he say? And this is, do we discriminate based on age, essentially? And even aside from this disease, just by nature, he's closer to his death based on life expectancy. I don't know any source to determine who you should prefer in this case. I think if you ask someone on the street, sort of the immediate reaction would be to say, well, obviously you prefer the younger person. But there are some problems there. That would be a form of age discrimination potentially, which again, all of triage is a form of discrimination. The question is this the type of discrimination that we want to do? Meaning, you'd say we discriminate in favor of patients with a higher chance of recovery. Most people would say, all things being equal, that sounds like a reasonable discriminating factor, right? But age discrimination, that's not at all clear. So Rav Asher Weiss it does not say that you should favor the younger patient. Again, this is different than the factor of whether the person will live a full life after recovering. But if you have a terminally ill person, that in such a case you would prefer the person who can live a full life. But there's no source to say that a full life of 30 years is any less valuable than a full life of 60 years. So those are his principles. And then this larger question someone asked, it's a surprising question. Can a doctor prefer one patient to another because he was paid money? You go to the hospital, you say, okay, I know you're treating all these other patients, but here's $100,000. Save save my father. So he says to do that, for a bribe, davar mechor, this is disgusting, and bribes are improper, and I'm surprised anyone would ever permit this. I don't understand what the question is. So that's his clear view there. So again, that's a general summary of those principles with this additional one. Rav Yitzchak Zilberstein, a major posek in Israel, he writes similarly that this focus on kedei l'tapel b'nifga beinoni, the general preference if people arrive at the same time is to treat the middle patient who has the best chance of recovery but needs the treatment. But that's only true if they come at the same time, not if the patient with a worse prognosis is there first. Ulam, if you by stopping treatment on one person you can save many lives, then the principle of not passing up on mitzvos, which was his principle for not stopping to treat the patient with a lesser prognosis. For the one with a better prognosis, that doesn't apply here. To save many lives, you might override that principle. So we're going to see this is controversial. We'll see who relies on that and who doesn't. Rav Moshe Feinstein and Igros Moshe, and really he sort of sets the stage for all of these issues. Rav Moshe Feinstein, of course, the leading posek in America, maybe in the world in the 20th century, dealt with all these new medical questions that came up as medicine advanced, and really everyone is basing themselves on his work and developing it in various directions. So he says, he makes this simultaneous versus sequential distinction, right? If two people arrive at the same time, then you treat the one the one with the better prognosis. But if the first one arrives, you can't stop treating the first one. So we're not gonna read through that just for reasons of time. And again, he also makes the chances of survival and the difference between a full life and versus a possible life. It's not clear if the person will recover. You favor the person with a better prognosis. One final point from Rav Moshe Feinstein that's very important, and I'm going to read it inside for that reason. He says some people have raised the issue the principles Rav Moshe set out are you sort of figure out who has the best chance of recovery and who has a chance of recovery to live a full life rather than someone who would recover but then be a terminally ill patient. So there's a worry if you make that calculation. Yesh ulai lachosh sherishayim. So maybe some, use a strong language, some evil people will say that we can take into account other factors too. So maybe someone will say, okay, if we're taking into account how long you're going to live, meaning if you would live for less than a year, that patient is not preferred, whereas if you live a full life, that's preferred. Maybe we should also discriminate against people with disabilities. Say if someone is mentally incapacitated, a shoteh, so maybe we shouldn't save their lives and we should save the lives of people who are fully mentally healthy. Or maybe we should say that someone who's in a wheelchair, who's injured and can't walk, maybe we shouldn't save their lives, we should save the lives of fully abled people, prefer them over that. And again, he uses extremely strong language here. He says, thinking this way is what Rishaim do. This is what evil people think. The Jewish view, the ethical view, is that you don't discriminate based on a person's quality of life. If this is their life as it was, they were living a life of with whatever sorts of disabilities they had, physical or mental or otherwise. We don't discriminate. A life is a life. So the only difference is on whether the person will live a full life or not, and the chances of the person recovering or not. But there's no discrimination based on what the person's life looked like, whether they were fully abled or not. So very powerful language from Rav Moshe. And so then the worry is, can you even make the calculation about whether the person will live a full life or not, a full lifespan or not? And he says he's not worried that people will jump to make this unauthorized form of distinction, whereas people will be able to see the difference. So he's okay with making his distinction between whether the person will live a full life after recovering and has full chances of recovery, and doesn't think anyone will discriminate against people with various disabilities. We'll return to this theme a bit later. All of this is sort of the normal issue of triage under normal circumstances, where generally hospitals have enough material to have enough resources to treat everyone, and there's the odd case of in Israel, the people writing about suicide bombings, where there's a short-term lack, and the question is for people in the field or maybe a hospital that's immediately overwhelmed, what to do. In our circumstances under coronavirus, it's under COVID-19, it's just a totally different scenario, because the worry is, and again, we've mostly averted this, but not fully, the worry is that all hospitals will be basically totally overwhelmed. And there just won't be enough ventilators to provide people with the best treatment. And there's a real need to prioritize and to triage if you want to save the most lives. Of course, if you didn't triage, well, let's take a quick look. An important article in the New England Journal of Medicine by Ezekiel Emanuel, who I believe is an observant Jew and is also one of the leading public health experts. He was under the Obama administration. I think he's at the University of Pennsylvania now. So they published a series of guidelines. This is just one chart, but it sort of gives some of the most important pieces here. Maybe the most important line for our purposes is first come, first served should not be used. This idea of first come, first served, if you come first, you get a ventilator. If you come later, too bad. And even if you're a better candidate for a ventilator, you won't receive it. That should not be used. Instead, the idea is to maximize benefits of saving the most lives and saving the most life years, meaning reserving the ventilators for people with the best prognosis and having the fullest possible lifespan after the fact. So that's a very different view. That's divergent from, let's say, the classical Jewish view, which has worked very well certainly in Israel and in America when it's come up, has worked well with normal health circumstances. But the question is, and I think these guidelines have largely been followed by hospitals, if a hospital wants to follow these guidelines, what is Jewish laws, what is halakha or Jewish ethics view of that? Is that a valid approach or not? Is there a way of squaring this more or less with halakha? Or if you don't, right, the reason why this is the preferred option, according to current medicine largely, is that this is the way you save the most lives. If you reserve the ventilators for the people who have the best outcome, you end up with the best overall results, the most lives saved and the most life years saved. So this is, some people call this utilitarian. It's certainly focusing on the results, even though it may be uncomfortable, or there may be some things you don't enjoy doing when you have to turn people away from treatment that would be helpful for them, but would be more helpful for someone else. This comes up in the context of halakha has what to say in a variety of contexts. One of them is when hospitals are coming up with their protocols, or when they did this a couple months ago, they'll often consult with either with ethicists, including with rabbis, or maybe there are doctors on the committees who are in touch with rabbis who are dealing with these things. That's one vector, one place where that will influence a policy. Then, of course, there are, aside from coming up with the hospital protocols, there are individual doctors who need to know if what they're doing in the hospital is ethically okay from a Jewish perspective, and if they should have any reservations about doing things. And then finally, sometimes patients will have preferences. Again, there's a limit to how much patient preference comes into play here, given how hospitals are overwhelmed, but they may be able to invoke their religious ethical preferences. So I'm just sharing here source number 13, just a virtual conversation I had with someone who's on an ethics committee for a large hospital system. We were in touch about various things, and they mentioned that people the hospitals are coming up with protocols, and they want to know when they're interacting with their Jewish patients what the views are, and what in terms of vent placement, do you put in the vent now or not later? And we'll talk about the practicalities of that in a second. That's one place where hospitals would come in touch with halakha and Jewish ethics on this issue. So we're going to look now at a couple of different ways of responding, of applying halakha and Jewish medical ethics to these issues. Before we do that, if there are any questions anyone has, please feel free to ask, and we'll talk about that, and then get back to the sources. Aviva, you might be on mute. Let's see. Can I unmute you? Oh, you're off. Okay, good. Yes.
Hi, Rabbi.
Hello.
I thank you for these sources. I just kind of want to be more clear in terms of what we just read, because they seemed more like general guidelines of ethics and less so based on like what we were reading in the very beginning, like Talmudic texts. And I'm trying to kind of see exactly how these two aspects interact. Like, Rabbi Steinberg really seemed to not be quoting any text, and so I'm just curious, like how much Jewish texts they use and what the halachic influences are.
Sure. So I'll say two things. First, you're absolutely right in the sense that there aren't so many, there aren't so many traditional sources, at least let's say pre-20th century sources on these issues. There are some, and oh, hello. There are some, but not as many as you might see elsewhere. To be fairer to the Rav Steinberg Sefer, his Sefer has a bunch of footnotes, which I of course didn't include because it wouldn't aesthetically wouldn't work so well, it'd be confusing. But there are some sources. Most of the sources are from recent years. But if you think about it, go back to the Gemara. What was the Gemara's source of the prohibition against killing someone to save your life? It's a svara, right? You don't need a source for that. It's logic. And similarly, if you look at a lot of the contemporary poskim, they'll invoke also logic. For example, they'll say, well, if you have two boats and one boat has 10 people and one boat has 20 people, you save the boat with the 20 people over the 10. And then it's just logical to extrapolate from that, I think what Zilberstein says, and say you always prefer saving more people as opposed to saving fewer people. The one source that I think is not, it's not svara, is not quite logical in the direct sense, but I mean, it's a different form of logic, is the question of ein dochen nefesh mipnei nefesh. This idea that if someone has treatment first, you can't stop the treatment. That's not immediately obvious. That's based on sources, right? That's based on the Mishnah about not killing the baby that's being born, and the logic in the different achronim. Again, there's about 3 different theories. You sort of gain the right to treatment once you start being treated, or the person treating you ein dochen nefesh mipnei nefesh, citing that Mishnah. Or maybe this idea of, you're doing one mitzvah, you shouldn't stop doing that mitzvah. Exactly what the formulation is, it might differ, but those are essentially Jewish principles. From a ethical perspective, there's a distinction here between what one might call a consequentialist or maybe even utilitarian perspectives, where you're focusing on the result, a distinction between that, and deontological perspectives, where you focus on duties and obligations. And in those cases, you would say the obligation to the patient in front of you is such that it prevents you from doing something that would optimize your bottom line, give you the best results, the most lives saved. So that, I would say, that's something that where sources are invoked more, whereas usually it's common sense, again, often with Gemaras as parallels, but I think the main force of the argument is often common sense. Other questions?
Is there any direct discussion about cases of somebody who can make a major do you hear me?
Yes, I heard your question, and we're going to get to it. The question: someone who can make a major
contribution to society versus somebody.
Great. So we're going to get to that later. So hold that.
Sorry.
Okay. Other questions, or should we go forward?
We had a question actually posted from somebody on Facebook. It says, is it permitted to use financial resources or protexia to get access to a dialysis machine? So let's say for a COVID patient who needs one in a time of shortage.
So that's interesting. So all the discussion we've been having has been from the perspective of from the perspective of the hospital, so to speak, or the overall medical system, which is a third party. In terms of preferring one's own health and acting to to obtain resources. So I think generally the principle we have is if you're not directly hurting someone else, chayecha kodmin l'chayecha vercha, you're allowed to take action to prefer. To give preferential treatment to yourself. Of course, in many areas of life, we do this without thinking. For example, we have private property and don't share it all equally with everyone. So the general view is that if you're not taking something away from someone else, you're allowed to pursue things that will help you medically as well. the question of using protexia or whatnot, so it depends on the context. If using protexia means that you're having a doctor not tend to the patient that they should be and instead tend to you, that's not okay. If there are ventilators out there in the world that you can get access to that aren't already supposed to be used by the hospitals, that might be a different story. So it would depend on the specifics in terms of whether you're doing something improper, but generally you're allowed to, if you're not harming someone else, you're allowed to prefer your own interests. Let's move now to some of the treatment in the current issues. Rav Herschel Schachter published a letter of Halakhic guidance on this issue earlier this month in 3 different versions. I think the final version, I tried to include the things that were added. We'll quickly run through that, and I'll try to make I need to reshare the screen, and I'll make the size bigger, and we'll run through that and try to understand the principles at work here. So he talks about, he starts in the case of the simpler case of if two patients arrive at the hospital at the same time, and there's only one ventilator, and you need to decide who to give it to. So one person it'll almost certainly help, the other person it may or may not help. You obviously prefer the person who will certainly be saved over the person who might be saved. And I think you could extrapolate that, the person who has significantly higher chances over one who has lower, even if it's, let's say, 40% and 10%, which is probably more what the numbers are like, at least in New York. But if they come one after the other, and this is what we saw in Rav Moshe and others, on the ventilator, and the first one's already connected to the ventilator. He's not young, he's sick. Virak safik im it may or may not actually help. The next person is younger and more likely for the treatment to work. This is where we have the principle that we don't set aside one life for the other, and you leave the ventilator with the first person. So this is essentially a continuation of Rav Moshe Feinstein's psak. The problem is, if you apply this principle, let's say all the hospitals knew that all the Orthodox Jews who came in would not ever be willing to be taken off a ventilator. Let's say you wanted to apply this principle, that you never take someone off a ventilator. So the logical thing for the hospital to do, if they want to maximize lives saved, would be to not put the person on the ventilator in the first place, if they have lower chances of survival, in order to save it for the next person, right? So say, well, we don't think ventilators are best for you, and they save it for the next person. So if one takes the position of never taking someone off a ventilator, you run that risk or that challenge. And then the hospital might say, well, if we know that you're going to fight tooth and nail to never be taken off, we just won't put you on a ventilator in the first place. So what we'll see here, responding to this challenge, is a few ways in which Rav Schachter in his tshuva, and then the other guidance, but from Rabbi Jason Wiener, citing Israeli poskim, several ways of allowing for like a minimizing of this challenge. So he writes, Achein, however, im bisha sheba hazaken hamasukan tchila, when the sick elderly person, the person with low chances of ventilator helping, comes first, if kfar yodim rosh sheba od shashtayim yaviu leisacholin od cholim tzeirim briim kiken kara b'chol yom. If you know, and tragically this has been the situation, that in just a matter of hours you're going to have more people who will come to the hospital with better potential results from the ventilator. Ubar adavar she'ein maspik ventilators avar kol cholim, and there aren't enough. There's a triage situation. That also counts as them coming simultaneously. And this is a fairly novel psak. I think it's been cited in the context of Israel, but maybe here or there. But application here is new. That we can say vas achas, coming simultaneously. It doesn't literally mean simultaneously, it means more or less at the same time. So even though this patient comes now, the patient with a low chance of survival comes now, and there's no one else here now, but someone will come in an hour or two, that also counts as bas achas, and we can tell that first patient, I'm sorry, we actually need the ventilator for someone else, even though that someone else is not here yet. So that's a big chiddush, so to speak. That's a novel point that resolves some of the pressure here, because hospitals will say, okay, so we're just not going to put people. If you don't want us to take people off of ventilators, we won't put people on ventilators if they have a low chance of survival. And that way, you still would end up maximizing the lives saved. Because again, the challenge here, and this is not obvious, right? The challenge here is how to optimize the results without violating dochen nefesh b'bnei nefesh, without setting aside one life in favor of another. And the view here is that if someone's on a ventilator and you take them off, that would be dochen nefesh b'bnei nefesh. But if they weren't on the ventilator in the first place, turning them down and saying, well, we have another candidate, even if that other candidate isn't here, that doesn't violate ein dochen nefesh b'bnei nefesh. This, we'll skip the next paragraph. We'll get back to it later. And this paragraph was added in one of the later drafts. In the third version, I think. So he notes to clarify that this preference for a younger patient over an older one, he doesn't literally mean a younger patient versus an older one. He means a patient with chances of a full recovery for a full life. So that's an important clarifying point. And now there's a new question here, or a related question. Again, you have a scenario where someone is the elderly patient, or the more precisely, the patient with a less chance of recovery, is connected to the ventilator. So, and other people are waiting for the ventilator. They sort of need it, but you don't want to take off the patient with a low chance of survival. So he says, the proper procedure should be, you can't take him off, but you should say DNR, do not resuscitate. Don't provide any extraordinary measures to save the person's life if they're in distress, because there's a need for this ventilator for another patient. So you don't, as it happens, I think hospitals are minimizing, many hospitals are doing DNR for many COVID patients because it creates all sorts of risks for the doctors. But leaving that aside, the factor here is, we can't say dochen nefesh b'nei nefesh. We can't say to take this person off, but we can say passively, we're just not going to resuscitate them if they die. That is a proper practice in order to possibly free up a ventilator for the next person without actively killing them. And he points out, you're not killing someone. You're not actively killing someone. You're just not fulfilling the obligation to save a person's life. For that, if those are the stakes, just not that it's murder, but you're not saving someone, it's permitted to do a DNR in order to save the next patient who needs a ventilator and has a high chance of recovery. And now, a third factor, so again, just to review, the first factor is when people arrive at the same time, favor the patient with better chances of survival, but not if the person's already connected, even with a low chance of recovery, you can't take them off. The three factors are, number one, you can say that it's vas achas, that you have other candidates, even if they're not here yet, if you know they're coming, number one. Number two, that you can say that someone who has a low chance of recovery who already has a ventilator will be DNR. And then third, this is a technology we mentioned before, so using what's called split venting, using one ventilator for multiple patients, maybe 4 patients. And there's 2 questions here. We're just going to summarize outside 2 possible concerns with split venting. One is that there's a certain risk to the patient when you move them onto the split vent. And is it possible to take a risk with a patient's life in order to save their life? And the answer to that is yes. That's part of the rapo yirape. The pasuk saying it's permitted to practice medicine. It means it's permitted to practice medicine even if you increase risks, as long as your ultimate goal is to save them, to improve the chances of recovery. And then the other concern is that by split venting, you decrease the chances of survival for those being split. Meaning you have better chances of survival being on a ventilator by yourself versus being on a split vent with someone else. And if, let's say, what you say is your policy would be people with a low chance of recovery, and also you can only be put on you can only be split vent after first being ventilated individually. So the hospital policy would then be, well, everyone gets put on a ventilator. If we run short, we then combine patients with lower chances of recovery onto a single ventilator and free up an individual ventilator for someone else. So the question is that the equivalent of taking someone off a ventilator and killing them. But his response is, since there still is a good chance of them recovering by being split vented, that doesn't apply. That's the other concern that's added in a later version because of new clarifications of the medicine. Essentially, though, there's a tightrope walking going on here. On the one hand, we keep the principle that no one is ever taken off a ventilator. That Rav Moshe said, that others said, you never take someone off a ventilator, but there are some ways of mitigating the results of that in terms of, if, first come, first serve policy straight up would mean that many people would lack a ventilator. So there are a few different ways of allowing for freeing up ventilators, namely, number one, sometimes not putting people on a ventilator in the first place because you say, no, we have other better candidates, even though they haven't shown up at the hospital yet, but we know they're coming. Number two, that you can say that patients with low chances of recovery on a ventilator are DNR. And three, split venting, which lowers the chances of survival, but frees up more ventilators, and that's permitted as well. Those are Rav Schechter's views here. The views offered in a post by Rabbi Jason Weiner, who's a chaplain at a hospital, and he has a book on medical ethics in Halakha. So he gives the following set of principles, some of which will sound familiar, some of which are new, and we're going to look at that in detail. So we'll start with his summary. First, triage as well as possible to try to avoid need to withdraw any treatments, meaning only put people on a ventilator first if you're not going to take them off later, or you're not going to want to take them off later. The goal is to save as many people as possible, prioritize patients with better overall chances of survival, and with potential to live a full lifespan, instead of someone terminal who lived less than 12 months. And again, based on the discrimination points we saw before, decisions based only on clinically relevant health of patient, not their age. Or it's not about your age, it's about your chances of survival, how long, and how long you would live, etc. Now, if a patient would likely not survive, right, you're on the ventilator and you have very low chances of recovery. Other patients need the room ventilator staff, right? This isn't just ventilators, this is all sorts of hospital resources. It's ideal to withdraw further interventions in order to allow them to die naturally rather than withdrawing. And this is what Rav Schechter said, the DNR. You don't take someone off, you put them on DNR. That's preferable. But number three, and this is the new piece, if there's no other choice, and it seems clear that a patient currently on a respirator will die soon anyways, withdrawal of a respirator can only be considered on a case-by-case basis in consultation with a posek. So there are scenarios in which he's willing to say that you can consider withdrawing a respirator or a ventilator or whatever the case may be in a case if the patient is likely to die soon anyways, they have a very low chance of recovery, and then there may be ways of removing a ventilator. So how can this be? This goes against the Rav Moshe, this goes against the standard view. How do we get here? And we're going to now explore some of the sources on which this is based. First of all, Halakha recognizes that people, even when they're close to death, there's not only is it not permitted to do things that would lead to their death, but that can even be murder. The Goses bidei shamayim shu chayev. Everyone agrees that if someone's a Goses bidei shamayim, that is naturally, close to the end of through heaven, through not through being killed by someone, but through natural causes, is close to dying. If you kill that person, shu chayev. You kill that person, you get the death penalty for that. That's considered murder. So you certainly can't intentionally kill someone who's close to death. And the Shulchan Aruch, based on Maseches Machos and the Rambam, says a goses, someone towards the end of life, you can't move them around or touch them or do various things. Kosher and the chayav, tie their cheeks. Some can also put oil on them, basically to start the tara process early. Or you can't do it, but you can't really move them around at all, or move pillows and that sort of thing, because that may lead to their death. So you're not allowed to touch them or move them around if that will lead to their death. And the Ramah spells this out. You can't cause someone who's dying, or a goses, to die quickly. If someone is a long-term goses, is close to death for a long period of time, and they're just not dying. You can't remove the pillow from under them, because that might kill them. Aval, if there's something that's somehow artificially preventing them from dying, if there's some loud banging noise, the Gemara seems to assume that loud banging noises prevent people from dying. Or he has salt on his tongue, and that that's like a stimulant or somehow keeping him alive. These are artificially preventing the person from dying. The person by nature would be dead by now, but they have these external things keeping them alive. You can take him away from there, meaning move him away from the noise, or remove the salt. Maybe this is referring to the salt. Remove the salt from his tongue. The aim is at masaklal. You're not performing an action. You're not moving the person. You're not shaking up the person. You're not killing him directly. Elashem mesir hamonea. You're removing a preventive thing, a preventive item. So there's this salt is externally, artificially preventing the person from dying. By removing the salt, you're allowing them to die naturally, but you have not killed them. And this is permitted according to the Ramah. This is a scenario where someone is at the end of their life. They're in great pain. They're just not dying. So to sort of help put them out of their misery, so to speak, you don't kill them directly. That's prohibited, but you stop the external prevention of their death. The Taz Nashach clarify that that's what he means. This view, one might argue, you can apply that here, at least if you have patients who are weak enough. And in fact, Rav Zalman Nehemiah Goldberg, in an article over 30 years ago, argues for just that. I don't think we're going to have a chance to read it, well, definitely not all of it, even the selections I included here, inside a funny scenario where you have, this is I think like some respirators, but on the old system, where you had one person on a respirator with very low chances of recovery, and someone else you needed to put on a respirator, not for them, but I think they were brain dead and you needed their organs for a third person. So can you take person A with a low chance of recovery off a respirator in order to put person B on the respirator, who's also going to die, but to save their organs for person C, who could recover and live a full life, if I got the story correctly there. And he goes through this Ramah and says that the basis of this Ramah is that if you remove an external factor, that's not even considered causing them to die, right? Because he argues you're not allowed to cause someone to die, even if they're close to death, even to save someone else's life. But but according to his understanding of the Ramah, removing an external factor is not, you're not doing anything. You're not doing anything at all. You're removing something external and they die on their own. There's no problem per se in doing that. And he says in such a case, it's better to do it. You shouldn't pull out take the person off the respirator if they're going to die immediately. Better to do it if, let's say, they need to change every so often. You need to turn it off and change he says the nylon, change the plastic. I don't know exactly what the details are. Every so often you need to sort of cycle through. So that's a good time to take them off. If you take them off anyway, you're just not putting them back on. That's preferable. But essentially he rules, let's quickly read the conclusion. Well, this person who is on the ventilator, person A, has a low chance of recovery and won't live 12 months anyways. You can take off this lung machine in any scenario, even if they'll die soon. It's better to do it so they won't die immediately, but to save another person's life, you can remove you can remove them from what's keeping them alive, because it's not doing anything. It's removing an external factor. And to save another person's life, that is permitted. So this would be the basis of taking people off of ventilators. The logic would be the same. Assuming the person currently on the ventilator has a low chance of recovery, won't live 12 months, taking them off the ventilator is an external cause. That would be the logic. We're not going to read through all of Rabbi Wiener's summary here either, but he says usually extubation, so taking the tube out, meaning removing from a ventilator, is forbidden. There's a minority view of the Ramah that allows it because it's considered to not be actively doing anything. If there's a severe shortage and you want to save someone's life, there may be room to allow for this. And the goal would be to save as many lives as possible. The preference would be to withhold rather than withdraw, as we saw, to not give the person a ventilator in the first place. Or to do DNR, but if you're going to do it here, do it, but it's preferable to do it where they won't die immediately. That's the view that Rabbi Wiener put forward, which I think is the sort of thing that would correlate better, would correlate more fully with hospital practices. One alternative view that I haven't seen people discuss much, but is on the books as New York State's task force, their conclusions on how to allocate ventilators. And on this panel, interestingly enough, is Dr. Howard Zuckier, not related to me, but on the news a lot. The Commissioner of Health, I think, for New York State, and Rabbi Bleich, Major Posek. So they have an approach where they say, first, people with a low chance of recovery, one should put them on a ventilator, but say that it's a trial of therapy. You're not putting them on a ventilator long-term, you're putting them on a ventilator for a trial period of 48 hours or 120 hours, 2 days or 5 days. And then after that point, you reassess. Now, I think from a halakhic perspective, it's not clear that this would make a difference. Meaning once you put them on a ventilator, just because you say it's a trial period, doesn't necessarily change the treatment. You're still taking them off. And if you're taking them off actively, that would be the problem of ein doch nefesh mipnei nefesh, potentially. I wonder, I didn't see anyone discussing this in the article, but what if you put someone on a timer? This is sort of a very Hilchos Shabbos solution, and I don't see any hospital adopting it. But in theory, if you put someone on a timer, you put a 48-hour timer on the ventilator. So would that help? Again, according to Rav Zalman Nechemia, that helps to some degree. He prefers scenario where you're not actively taking it off, where had to turn off anyway. I don't see that solving the ein doch nefesh mipnei nefesh problem. You're still making by when you put it on, you're only giving them partial treatment. It's not at all clear that would be a good solution. We are running out of time, but maybe very, very quickly. The Mishnah in Horios talks about how there's a whole list of preferring, in terms of saving lives, a man to a woman, a Kohen to a Levi to Yisrael, etc. All these different groups. And then the Gemara says that doesn't really apply so much. Emasai is manchakul and shavin. That's only if they're all equal. But the real factor that makes a difference is a person's Torah knowledge. Right? That's really in the Mishnah already. Talmid Chacham, the Kohen Gadol, Mamzer Talmid Chacham Gadol Amaretz, Mamzer Talmid Chacham Kodem. You prefer the greatest Torah scholar in such a case. And there's a couple of different reasons for it. The general approach is that it's based on who's the most helpful for the community, but with a certain focus on Torah study. This, in theory, this source should determine our whole discussion. It sounds like it's the most relevant source, but Rav Moshe Feinstein, decades ago, said that really the most important thing is the health factors. Maybe as a tiebreaker, if people are exactly even, you can consider these factors, but it doesn't come into play. One thing that some people apply, and this was Bina's question, that what if you can save someone who's needed by the community, and maybe that's like we saw in the Mishnah Horios, maybe that's considered like many. Maybe saving a doctor who can cure cancer is the equivalent of saving 1,000 people, or maybe saving a community leader, a politician, who's actively involved in fighting the disease, or whatever scenario you want, or a religious leader. Maybe you can say that counts as saving many lives. That somehow is given greater weight. So Rav Zilberstein apparently suggests this. Rav Asher Weiss, this is in the notes in Ray Wiener's article, Rav Asher Weiss doesn't think that that's a priority. It's too hard to determine. Generally, I've never seen this factor applied. Even Rav Schechter in his article seemed to give some room for people, to leave some room for people who are communal leaders, but it's not applied too often practically. The factors in the Mishnah and Horios seem to be superseded by medical classifications generally, and maybe it remains as a tiebreaker. One final thought, because we're out of time. I find it fascinating to do a comparative analysis between the Orthodox and conservative protocols that have been written. Fascinating, because usually you assume, okay, the Orthodox will take this position, the conservative will take that position. There'll be some sort of a range, but you'll be able to plot them out on a straight line. As it happens, if Rav Schechter and Ray Wiener's views are somewhere in the middle, the two conservative protocols released by the Rabbinical Assembly are on both extremes, on the two extremes. Rabbi Elliot Dorff argues that really you should, there's no difference between not giving a ventilator and taking off a ventilator. And he says this differs from authorities in the Orthodox world. But he basically rejects the concept of distinguishing putting on and taking off. This is a major philosophical question of doing harm versus allowing harm. Is there a difference or not? So I assume he has some conclusion. I didn't look at his article that he cites, but I assume his conclusion is that there's no essential difference. At the end of the day, you're leading to the same results, and therefore he says you can take people off a ventilator. You don't need to ask all the questions like Ray Wiener was saying. So he's all the way on the side of essentially follow the hospital protocols. If you need to take people off a ventilator, you can do that, no questions asked. Of course, he has many other details, but for our purposes, that's his view. Rabbi Daniel Nevins has the view, he really takes issue with essentially what the standard protocol in hospitals is from Dr. Emanuel's protocol. And he says this is against the traditional Jewish view of Rav Moshe Feinstein and others that you don't take someone off a ventilator. You ein dochin nefesh mipnei nefesh. You leave the person on the ventilator. You can't take someone off. And to say I prefer you over you, that's just not a proper Jewish view. So he's on the opposite extreme. He's agreeing with Rav Moshe Feinstein's view and not updating it, not changing it, not shifting it in light of the new circumstances. So I have a bit of a theory as to what's going on here, because usually you'd think there would be some sort of alignment in a different way, not necessarily that the two extremes are two rabbis in the conservative movement and the sort of two centrist views are in orthodoxy. So I think there's two different factors that are here. And this ties into the different ways that people would be asked these questions. But one fact that these questions would come up. One factor is accommodating hospitals, meaning trying to fit what hospitals are doing with halakha as much as is justified. So what you don't want, if a doctor comes to you and says, the hospital wants me to take someone off a ventilator, is this permitted? So if you say this is prohibited, you must decline to do that, or and if you get fired, well, you can't murder someone to save your job. So there's a great interest in having hospital protocols aligned with halakha, or at least something within the range of halakha. That's one factor. The other factor on the other side is, of course, Jewish values. And obviously, no one would want to compromise halakha's integrity or halakha's beliefs, or what halakha considers to be murder, just because something's practical. And that, of course, is the idea of ein dochen nefesh mipnei nefesh, that there are some cases where there's a principle that something is deontologically prohibited. Something is just, you have a duty to this person, to this patient in front of you who's on the ventilator. You can't just take him off and kill them. That would be against Jewish ethics. And I think especially now, and this gets into the questions of discrimination, which, as we saw, Rav Moshe Feinstein was very opposed to applying discrimination against people with various disabilities. So I think if you read Rabbi Nevins's article closely, he says he's very worried about that. He's very concerned that as soon as you say you're going to prefer one person to another, instead of adopting a first come first served policy, you're going to end up exacerbating these inequalities and this discriminatory impulse that we have, even when it's not medically justified. And for that reason, he's very opposed to taking the person off the ventilator, and he takes the opposite extreme. So I'd say the two conservative tubos represent the two values in purer form. Or Dorf saying we want to accommodate, we want to be on board with the hospitals as much as possible and figure out how to make that work. Whereas Rabbi Nevins is saying our goal is to make sure that the Jewish values are maintained. It's maybe less pragmatic, less practical, but how can you take someone off a ventilator ever? And the two Orthodox, recently published protocols we saw are somewhere in the middle, saying, well, on the one hand, we believe ein dochen nefesh mipnei nefesh. You can't just take someone off a ventilator like that. On the other hand, we're trying to save as many lives as possible, and we're trying to work with hospitals. The hospitals have the goal of saving as many lives. We're trying to work with them as well. And there's the two different degrees of how much give to have. Rav Schechter giving a few different methods, either saying that Bas Achas starts earlier, or saying you put a DNR, or allowing split venting. Rabbi Wiener saying, based on Rav Zalman Chaim Goldberg and others, maybe there are some cases where you can take someone off with great care, in certain precise scenarios. But that's the goal. That's the goal, to balance between these two competing factors, trying to optimize halakha's response to these challenging circumstances. And we're over an hour. I'm happy to take questions now. And it's been wonderful learning with you all. I think there were a couple hands that went up over the last few minutes. Okay, if not, everyone should feel free to reach out to me if there are any further questions. And it's been wonderful learning with you today, and look forward to learning with whoever is interested the next 3 weeks.